is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for attending the STN monthly webinar. This session is being recorded so that it can be offered as on-demand CE for our members. Your lines are muted, but if you have any questions during today's presentation, please type them into the question queue and they will be answered at the end of the presentation, time permitting. STN is an accredited provider of continuing nursing education. To claim CE for this session, you must attend the entire session and complete the online evaluation of the presentation. If you are attending this session live, you will receive an email about 1 hour after the event with directions to complete the evaluation. Certificates will be emailed approximately 7 to 14 days after today's event. If you are viewing this session as on-demand CE, you'll be able to download your certificate after completing the quiz and the evaluation. The presentation from today is saved as a PDF in the handout section on the toolbar. Today's speaker is Nicholas Mannering. Nicholas Mannering, RN, BSN, MBA, is currently the Trauma Program Manager at Mission Hospital Regional Medical Center. He has over 10 years of trauma experience. He currently sits on the board of the Down with Falls Coalition in Orange County. He is certified in both critical care and the newly developed trauma certification. Nick recently moved from Newport Beach to Costa Mesa with his wife and 2 children. His interest outside of work is that he enjoys being a do-it-yourself worker around his house. He loves the game of baseball and is a loyal fan of the Kansas City Royals. When he gets the time, he likes to get out, get to the game, and play ball as well. Please welcome Nick Mannering.
Good morning, everyone. I am going to be talking a little bit today about the geriatric trauma and how to deal with the paradigm shift in the changing from car wrecks, MVCs, shooting stabbings to the geriatric world, and hopefully some tips on how to make the geriatric activation use better uses of resources in your facility. So first of all, we all know that geriatric trauma and falls are a big part of trauma now. They're the leading cause of fatal and non-fatal injuries in adults greater than 65. So as we all know, 1 in 3 adults will fall, and that adds up to big numbers. During 2014, approximately 27,000 older adults died because of falls, and of course, 2014 NTDB analysis showed that 42% of all traumas nationwide occur from falls. So obviously a real problem in the trauma world, and it is making. So first of all, I want to talk a little bit about the history of my facility and why we had to make this change, and then we'll get into how I made the change and lessons learned from making this change. So first of all, I'm in Orange County, California. We are a population about 3.5 million people. We have 3 adult trauma centers and 1 newly formed pediatric trauma center. So we all cover a large amount of area. Orange County is a large retirement area. We have great weather, low elevation, so it's kind of a mecca of where retired people head. So we have over 500,000 persons over the age of 65 in Orange County. So personally, in our service area for our trauma center, we have the 3rd largest retirement community in the country. Estimated population is about 30,000 over the age of 55 live in that one community. And of course, in regards to accidental deaths in Orange County, we have far more deaths from the ground level fall than the motor vehicle accident. And of course, we're home to the Real Housewives of Orange County. We all do look like them, so in case you were curious. And there's a reason why Allergan, the maker of Botox, is headquartered in Orange County. All right, so this is another proposition I'm making. We've all heard of the lethal triad, and I would move to change it to the lethal trapezoid, adding the ground level fall to that, because as you know, this is probably one of the highest forms of death in most trauma centers, and it's not necessarily their trauma, but of course it's their comorbidities as well. All right, so history of Orange County and why this was a big deal. So April 1st of 2014, our county changed the field triage criteria to include ground level falls, any age greater than 75 with evidence of head or facial trauma. And all of those patients now had to go to a trauma center. So overnight, we had an influx of almost 5 additional patients a day. And then when it hit its peak, we were seeing almost 100 patients a month just related to this one single triage criteria. So it instantly overwhelmed our surgeons and overwhelmed our trauma bays, and it overwhelmed everything. So we had to come up with a real decision on what we would have to do to deal with this big influx of patients. So the first step was, do we activate these guys or do we send them to the ER? So the plan we came up with was a kind of a modeled system. So we created an additional level of activation. So much like everybody, we have our full, partial, and then we created a specific tiered system, the third tier for this specific group. And this is just an example of our activation criteria. It models very closely to what our county triage criteria are. So of course we have all the tier 1, which is our highest level, covers all the physiological things. And then we have our mechanism for our partial activation. And then down at the bottom, we have our tier 3 activation. We also put in which personnel is responsible for showing up. So of course, everybody comes to the highest level, and then we digress from there. So let's talk a little bit about the response for our level 3. So when I said we did kind of a mixed response for this to help with this, so we determined that these guys obviously have the high potential for injury. If they go to the ER, there's a good chance that they will be pushed to the waiting room, or the medics will have to hold them on the wall till they get a bed for the because of the higher acuity patients, because these guys don't appear to be hurt when they arrive to the facility. So that was the first thing we had to tackle. We decided where they would go and how to expedite. So we made it where they would arrive to our trauma bay, and then the response team would be an ED physician. We would cover them with a trauma nurse, and in our facility we use the trauma nurse clinician model, where the primary nurses belong to the trauma department, and then we will also pull in from ED and ICU. We also wanted a tech there to do all the tech-related blood pressure, monitor, etc., transport, all of the tech-type things. The lab was also a responder. In California, it's very difficult for anybody besides lab personnel to get a phlebotomy license, so lab was crucial. And then, of course, transport to help get the patient to CT. And then, of course, in the process, this is all about the stat CT. So the CT is notified of it. So the response worked very well. And if you notice, there's no surgeon in that, and that is on purpose. And this is kind of the gray area for the college. As you know, the admitted to non-surgical service, activation, etc. The ground level fall kind of is that gray area. So it says they're not really counted. So this is kind of our logic to not including the surgeon at this point. So of course, all these guys need that stat head CT. And I'll get into the numbers a little later, but most of these guys aren't really injured, especially just with the mild evidence of head injury that most of these patients came in as. But on the other hand, we wanted a trauma nurse to take care of these patients, because all of these patients, of course, are on some sort of anticoagulation now, whether it be aspirin, Plavix, or the new ones. But we wanted that expertise for reversal if there was a bleed. And then, of course, we have the surgeon in-house on standby. So what we found was we greatly reduced the time to be seen. So if you look on the left-hand side, that's our pre-Tier 3 model, and on the right-hand side, it is our post-Tier 3 model. So pre-Tier 3, the total time they spent in the ER was 216 minutes, and we reduced it by almost an hour to 165 minutes. And then the big one was time to be seen. So our average time to be seen on these patients before we made them into the Tier 3 and they would just go to the ER was 55 minutes. And now, of course, it is 0 because we've held the expectation that the ER docs will respond just like the trauma surgeons and be there at arrival or prior to arrival. So significant changes in this. All right, so some of the big barriers that we have identified were staffing. So to increase our patient load by almost double overnight took a lot of kind of work with administration. But luckily, as you guys all know, trauma keeps good data. So this is where we created, with the influx of these patients, we created our own trauma clinician model. Before, it was we staffed all of our nurses actually out of the ICU to come down and run the trauma. And obviously, when you move to 10 traumas a day, that pulls multiple nurses out of the ICU. So it was not sustainable. So that's where we came up with the mix. So we hired clinicians, but we still didn't want to lose the expertise of the ICU, and we still didn't want to lose the expertise of the ER. Because several of these patients, or most of the patients, have severe medical comorbidities where we need that ER expertise compared to the surgical ICU. So that was the first barrier. So luckily, like I said, we were able to take numbers, show that we need this staffing, and when all the patients came in and we staffed, of course, these are different patients than most trauma patients. They come between the hours of 9 a.m. and 9 p.m. So we staffed an additional nurse there. The second issue was physical space. So we have a 4-bed trauma bay, and getting 10 patients a day usually is not a problem, but as you all know, the traumas all come in at one time. So addressing physical space is one of the most difficult things. So this is where you have to work hand in hand with the ED to use their bays. Sometimes we bought this great thing, a folding room divider that we can double bunk patients in some of our bays. We do have the space. The other advantage to that staffing with the ED, they have built more of a teamwork, and we were able to get some of those patients into the ED much faster after we've kind of ruled them out with the CT. The very biggest barrier that we have come across is the EMS agencies. So like the picture in this slide, that is normal traffic every single day. And that's actually a picture of the 405 freeway not too far from our trauma center. So the EMS now had to make a very large change in the way they were doing things. So again, these elderly falls were happening every day in our community, and they were going to the local hospitals. And only having 3 trauma centers in Orange County meant that sometimes EMS was out of call for 2 hours dealing with traffic there and back. Due to the densely populated area, helicopters typically are not an option in our area. So that was kind of shot down right away. So EMS also did not see the advantage to this because, again, all these patients look fine. They just had a little bump on their head. So education was a huge part of the whole thing. We went to every EMS agency we could, did a presentation. Our other trauma centers joined us as well in the community to try and educate the paramedics on why this was happening. So based on our numbers, and when we looked at all of the data, and we've had nearly 4,000 of these patients, the ones who die come in with a GCS of 14 or 15. So this was really an important point to send to the paramedics. I don't think they realized, well, they didn't realize what was going on. So they would drop off a patient that was awake and talking, maybe a little confused, and they would never touch base with them again, and they would have no idea they had a huge bleed, ended up with a cranie, and death. So feedback was also very important in this point. Let's see. So the ground level fall, the question is, of course, what do you guys do? And I do have, before we get into the numbers, let's talk about the update. So I've just spent the last 5 minutes talking about how we educated the EMS, and we've worked very hard to get the feedback out there. Well, as of December 1st of this year, due to some EMS pressure, the county actually changed the criteria on us again. So due to paramedic dissatisfaction and long run times, they took the ground level fall out of the trauma triage criteria. So again, we had to completely redo our staffing model and how we were going to deal with these patients. So our goal was to not reduce the amount of care on these patients, but the county basically made it where we could not activate these patients anymore. So we had to come up with an entirely new system and we called it the TBI Alert. And the way that the TBI Alert has been set up is it's now run through the ER, because again, not allowed to activate, and we still respond with an ED physician and a trauma nurse, but it is a much lower response. We still have the Tier 3 alert, and those are solely for the patients on the Coumadin and the novel anticoagulation. Again, the logic between that is that those patients, you need the expertise to reverse the PCC, the FFP, all the novel drugs that the community hospitals will not have, or the expertise that they have. So that's kind of the update, and of course I write all these things about how great it is, and the county changes it all, so we have to be fluid, just like every part of trauma, correct? Fluid. All right, so let's talk about the numbers. We are working on doing a research paper on this. So the preliminary numbers, like I said, we had about 4,000 of these ground level falls. So we pulled out first the amount of head bleeds, and we pulled those out based on ISS greater than 3, or AIS greater than 3 for head injuries. And we determined that there was actually only about 175 of these patients. So it's a very, very low percent. So it's typically less than 1%. So the question we have is, how do we better fit this triage criteria to capture the guys that are going to have head bleeds? And like I said, out of all of the patients who died, they had a GCS of 14 or 15. So finding the guy that's alert and awake that has the head bleed compared to the guy that's alert and awake and does not have a head bleed. So we are working with the statistician right now, but so far we're not finding any good indicators that show. It was about 50% of our big head bleeds were on no anticoagulation or on aspirin, no or aspirin. About 20% were on Plavix, and then the rest were on either Coumadin or the novels. So our data shows that anticoagulation's really not even a good indicator. And the only minor trend that we were able to find out of the 160 that had positive head bleeds, we were able to determine that dementia occurred in about 40% of these patients. So far we haven't been able to, but hopefully more to come with more statistical analysis. We can better figure out what to do with this triage criteria. And again, this is a very hard area to determine, because we don't really even have a good ISS criteria to determine what is over triage as well. Now, the college would like greater than 15 for your full activation, and then you can kind of go somewhere between 5 and 15 for your partials. So less than 5 is really not even a good indicator at all. That's 2 abrasions in different spots, right, or a bruise and a scrape. So trying to figure this out is still up in the air. The one interesting trend that we did find when we went to look at actually if there was more than just head injuries. So we pulled AISs greater or 3 and above for both chest, abdomen, and pelvis. And out of those patients, we noticed all of them did have evidence of head or facial trauma. So weren't exactly sure why that's happening, but I guess when they fall and hit something major, they still hit their head and show that sign of head and facial trauma. But when we took all three of those into account, or we took all four, the head, chest, abdomen, pelvis into account, about 15% of our Tier 3 patients, or the ground level fall patients, did have a significant injury. So our over triage rate, if you go by that, is about 85%. We looked at the other two centers. One center in Orange County does not get a significant amount, so they weren't able to do it. And then the third center showed, using the same criteria, we had about 20% of it. So overall average through Orange County is about 18% of these ground level falls have a significant injury, whether it be head, chest, or pelvis. Then the final note that I have to talk about on the head injured patients, when I mentioned this GCS of 14 or 15, that of course makes it very hard to triage, but we figured our logic behind why these guys die and the way they present like this is, of course, the brain atrophy, these small bleeds. They, of course, have the subdurals where they pull their tear bridging vein, and then it just slowly builds, and then all of a sudden you get the detrimental injuries. And we noticed that pattern throughout. So these guys come in very, very stable, awake. An hour or two later, they're either in need of an urgent crani or, like most of the elderly falls, do comfort care with a massive bleed. And then since we looked at that as well, we also looked at data to determine when and who we do the repeat scans on. So we took our group of 4,000 patients and we looked to see if they had a negative initial CT, and if they had a negative initial and a positive second CT, we looked to see what the factors were and when the bleed happened. So first of all, the number was incredibly low. So we had 4 in the last 2 years out of the 4,000 patients. So again, not even a statistically significant number of initial head CTs and initial negative and repeat positive CTs to make it worthwhile to even keep these patients. Before we had, one was on Plavix, one was on Coumadin, one was on aspirin, and of course the other one was on nothing. So we're way up in the air on that as well. But based on those numbers, we changed our criteria that we do a repeat CT scan only on Plavix, only on thinner, and we do it within 3 hours. On those 4 patients that had bleeds, they all showed signs of significant bleed very quickly. And they actually, within the first 2 hours of it. But of course, being conservative and worrying about we'll miss everything, we did make it 3 hours. Before we did a repeat in 6 hours and then sent them home. So based on that data, we've actually been able to get patients out quicker and not admit them overnight for CT scans. But it's very interesting. That's the big thing everybody worries about, the initial negative, and then they develop. But based on our 4,000 patients, it's not statistically significant. We're working on putting that research together as well. So hopefully that'll be out soon within the year on that. And then the final note on the numbers, when I spoke about we changed to the Tbi Alert in December, and it actually got rolling in February. I've looked at the prelim numbers, and at this point we've had about 67 patients, and out of 67 we've had 3 with significant injuries. We've had 1 head injury, 1 C2 fracture, and 1 multiple rib fractures. So again, it's kind of showing our point of what do we do with this big over triage of the ground level fall. All right, so kind of the numbers. Let's see. Whoops, sorry. Get it. Sorry, just take a drink of water here. Sorry. All right. So, in summary, the ground level fall is the new form of trauma, and we are all kind of struggling to figure out what to do with these patients and how to triage them. And I feel from the knowledge I have gained in the last 2 years of figuring out different tier levels, changing criteria, these patients do need to be expedited. There is a high over triage rate, but there's also the high potential for injury. The mixed model of ED physicians covering until there's something bad seem to work very well in our facility. The ED physicians like it. They get a trauma nurse that's trained in everything they need, one-on-one care. They're there. They get to the CT right away. It makes their life easier. The surgeons like it because they are not overwhelmed with traumas that are potentially non-operative and potentially not hurt. The staff like it most of the time because, again, we've shown that it reduces time in the ED and it gets them to the right place sooner. So overall, I think the Tier 3 experience is a very good one for patient care. I don't have good outcome data at this point because we don't have a base group to go from, but that is something we are working on with the change, and hopefully, again, another paper. I guess I have a lot of writing to do. But overall experience, it's somewhat difficult to get buy-in, but well worth it in the end to get these patients in. So the advantages definitely outweigh the disadvantages in the Tier 3 level of activation. One note I did forget to talk about, the way we bill for the Tier 3 activation. As we all know, that's a big part of any bit of it. We did bill these patients as a trauma consult. So we have our full and partial activation, and we considered this a trauma consult activation. But as most of you know, in this population, they're mainly Medicare patients, and Medicare reimburses, I think last time I looked, about $700 for any activation fee. So that's not a significant financial impact in either way. So I would like to open this up to some questions. Like I said, this is kind of a hot topic. I saw it at East. They presented a paper out of Pennsylvania with the Tier 3 model. So we've done it several ways, and we've done it for 2 years. So I'm sure people have some questions.
Yes, there are a few questions right now, and I'm sure they'll keep coming in. As a reminder, if you have questions, just please type them into the question queue. And Nick, the first question, what was the time frame for GLF Tier 3 activation? What was your mortality rate during that period?
Okay, so our time frame was April 1st, 14 through December 1st of, 16. So it was almost 2 years, so 18, 19 months. So again, 4,000 patients. Our mortality rate was very low. So out of the 4,000, we had about 100 die. And again, all of those are the majority of them were comfort care or medical comorbidity issues on those.
Great, thank you. The next question, where were your patients admitted? Was it the ICU or somewhere else?
So both. Majority of them were admitted to telemetry. The large amount of these ground level falls were syncopal, and they required the syncopal workup of the telemetry unit. If they had any bit of a bleed, or they would go to ICU. We probably over triage a little to the ICU, but we feel that it's safe with this population and their large amount of comorbidities.
Thank you. What services are these patients admitted?
They're actually admitted to medicine, and that brings up a good point. So we created a very strong policy on what requires the trauma consult in these patients. So any sort of head bleed, C-spine injury, or multi-system automatically become a trauma patient. But besides that, they were medicine patients, because in reality, the majority of these patients needed a medicine doctor to figure out what was going on to make them fall. If we had the perfect world, I would admit these guys to a geriatrician, but as we all know, geriatricians are hard to come by. We have put in a request to get a geriatric nurse practitioner on the trauma team to cover these patients to make sure they follow up with all the important fall prevention techniques and the beers, meds, etc.
Thank you. The next question. Considering the staffing and EMS county ramifications, can you offer an algorithm template for what could work in other areas?
Absolutely. And if you would like, I can send out our activation criteria. I also do have kind of a flow chart of the flow of what it would take. But depending on your area, and I've worked several places around the country, urban, suburban, and rural, it really, really affects what gets triaged to the trauma center. For example, I worked at University of Missouri, which is kind of it is a very rural facility, and everything comes by helicopter. So trying to tell somebody they need to take a $70,000 helicopter ride with a 10% chance you have a head bleed at the most is really, really hard to get buy-in. So it's very region specific. But the suburban and the urban areas where it's short run time, it's much easier to get this taken care of. But we can, and like I said, with our change in county criteria, we control kind of who comes, and we've made anybody with the anticoagulation. Because some of our hospitals, and Orange County is not a rural facility, a rural county at all, but some of the smaller hospitals in our area don't even carry FFP or platelets. They are basically just glorified urgent care. So that's where we really worry about the anticoagulated patient going. So it's very county dependent, but if you have any further, I'm happy to help with any of that.
Thank you. The next question. So for the ones who had no initial findings, are they being discharged home from the ED? And if they are, is there any sort of balanced continued fall risk evaluation done prior to the discharge?
Yes, and this is probably one of the most important part that often gets left out in this patient population. What prevents them from falling again? So if you fall once, you're at 50% higher rate. So all these guys are 100% fall risk. So one of our kind of care plans that we do while they're here is get a social worker eval. Whether that assess their living environment. A lot of these people already come from assisted living, already have care. We own our own home health agency, and we created a fall prevention kind of home health set, much like the congestive heart failure to reduce the readmissions. It's very simple. We worked with them to front load the physical therapy to get them as strong as they could right off the bat. We also incorporated the basics of fall prevention. I think that's one thing that's left out in some of the home health things. We added a few other little things resource-wise to it and created a fall prevention set for home health in this. We also refer them to our county agencies as well. We offer the Matter of Balance classes. We offer other fall prevention classes. We go out to the large retirement community that has its own television station and do fall prevention on their, do a fall prevention TV show for them quarterly to help with that as well. But it's very crucial. We noticed there was a lot of readmissions and we've actually reduced them after we started ordering home health on everybody or a social work screen.
Thank you. Do these patients admitted to medicine service get a surgical consult? And what was the ACS COT thoughts on this?
So again, this is that gray area I was talking about. If you look at the Orange Book, ground level falls are admitted from your non-surgical service. So most of them that get admitted do not get a surgical consult of any kind. So if they break something, obviously ortho, and if they have a head bleed, then trauma takes over. But the majority are medicine. Like I said, the majority are negative and do not have a surgical issue. They are truly medical patients. So I have my survey in about 90 days. I will follow up. We did talk to people on Committee of Trauma. They did not seem to think it was a bad idea, but more to come in 90 days.
Thank you. Are your Tier 3 activations included in your registry inclusion criteria?
Yes and no. It depends. We use pretty standard NTDB inclusion. So if they're admitted, if they meet the NTDB, and off the top of my head, I'm blanking, so I apologize on that. We keep all of them in our registry for the whole purpose of doing these studies on them. But we don't necessarily upload them to NTDB if they do not meet the criteria.
This was mentioned from a previous question, but would you be willing to share your admission policy?
Yes, absolutely. Certain.
Okay, for those people asking for these, I'll just, if you email me after the webinar, I'll send those to you.
Awesome.
The next question, did you specify a time limit for a Tier 3 activation, such as GLF, within a certain time frame?
Yes, that is 6 hours. We determined that would be, and again, not exact data on this. We kind of just went by what past experiences and what we could do best, but it is 6 hours prior.
Thank you. Is this an NP or staff RN with additional trauma training? The trauma nurse clinician, that is.
It is a staff nurse with additional trauma training. Currently, I have 9 FTEs in my department that are all ICU background with extensive trauma training. The newest nurse I have has 9 years of experience, and those guys serve as my primary nurses. They're kind of the day-to-day charge nurse of the trauma. Then I also pull in ED nurses that staff trauma, and they solely are pulled out of the ER and work in trauma, and then additional surgical ICU nurses to staff. So based on our volume, we staff 5 12-hour nurses in a 24-hour period. And they're staggered, like I said, to 9 to 9's our busiest time. So we staff up during those times and down, just like anywhere else.
Thank you. How many patients did you activate in the Tier 3 criteria in that time frame?
It was 3,860 in the 2 years. So that's 1,700, 1,800. It was 1,700, I think, the first year, and almost 2,000 the second year. So very large amount.
Do you activate for ASA antiplatelet agents alone?
No. And right now, with our the way the policy is written for our repeat CTs, the ASA and the Plavix do not need a repeat CT and can be immediately discharged. But if they are on both ASA and Plavix, then they do need the repeat CT. Again, not real good data on that, but we figured that's doubling the chances, so we have to play it safe.
Thank you. Do you use a fertility index tool for those patients on arrival or shortly after admission?
We don't. We looked into that, but we haven't quite had a chance to institute that yet. We're working on that.
Okay, great. I had another person asking you to share the flow charts, algorithms, or orders, and I just want to remind everybody to email me after this presentation. My email address is c@traumanurses.org, and I will reach out to Nick and I'll get those for you. The next question is, what is your timeline for those on antiplatelet anticoagulation for repeat head CT prior to ED discharge?
So that is now 3 hours. It was 6 hours, and like I said, based on our data. But if we really look deep into our data, out of the patients we had, the repeat CT is probably not necessary in any of these patients that have the initial first CT. But again, not published yet, so we have to stay conservative because everybody has that one patient that was missed and they hold on to that forever.
Great, and it looks like we're out of questions, so I'll go ahead and call this webinar to a close. Again, if you have any questions or if you'd like some of this information from Nick, please send me an email. My email address is C as in Cody, Jones @traumanurses.org. Again, that is C as in Cody, Jones @traumanurses.org. Thank you guys for attending, and Nick, thank you for a great presentation.
Thank
Have
you.
a great rest of
And
your
I want to say I will be at STN next week if anybody wants to find me, and I'm happy to share whatever we have there as well.
Thank you.
Thank you.